hear me okay? Excellent. First and foremost, right out of the gate, I want to thank all of you for being here. You had a choice. You could have stayed at home and done something else. It's going to be a nice day outside. But certainly when it comes to education, and specifically the 12-lead ECG as it relates to ACS patients, there's a lot of things to cover and a lot of things to go over. So we're going to spend the day together today. Kind of give you a layout of the day. We are scheduled till 4 o'clock. Not to say that we're going to be here till 4. We might get done a little early depending on how things flow, and certainly questions from all of you. It's my intent to take an hour lunch break because I think it's nice to get away from some of this stuff, because I'm going to load you down with a bunch of information today. And I would imagine that some of you are going to feel like your brain is about ready to explode by the time you leave here. So that being said, we'll make this very informal. If you have questions, by all means, yell at me, throw something at me, let me know, and I will make sure that I address that stuff with you. Get this going here. So my background, my current role or position is the Training and Quality Assurance Specialist with Lucas County EMS, a position I've held for the last going on 13 years now. Prior to that, I spent 20 years in the field of Toledo Fire Department, spent a number of years at the University of Toledo in their paramedicine program. I almost hate to say this because it makes me feel very old, but I've been a paramedic for 40 years. And typically when I go in and teach, I'm usually the oldest and longevity person there, but now in this class, I think I have Barb as well as Tim. Barb, how long have you been a paramedic?
77.
77, so you got me by 2 years. Where's Tim?
Same.
Same?
Yeah.
All right, so they got me by a couple of years. This is a profession that I absolutely adore. I love. I think I'm more in tune and involved in what I do now from when I started back in 1979. It's something I have a great passion for. The cardiovascular system has always been one of my things that I like to go to. So very early in my career, I tried to gobble up as much knowledge as I could and hopefully pass it on to new paramedics as they come out into the field, and certainly have that discussion. I've been the primary 12-lead instructor for Lucas County as well as surrounding areas for the last 23, 24 years. When I first started back in the early 90s, I was very fortunate to link up with 2 paramedics out of the Florida area, Dade County exactly. And we put together this program many, many years ago, and we made some revisions to it throughout the years. We kind of separated our separate pathways, but I've kind of kept this going on my own. So I do have a great passion for it, and it's something I like to spend a lot of time with. So again, as we go through here, make sure you ask a bunch of questions, and I will try to address those as we go. So let me learn a little bit more about you guys. Typically when I do a class, I will go around the room and have you introduce yourself, kind of share with me what your experience is. But since how large this group is, I'm going to not do that and spare some time here. But let me ask a couple of questions of the group. How many of you are paramedics? I would like to say most of you. Some of you are still students or in this process of becoming a paramedic, is that correct? Any nurses in the group? You in the back? Excellent. So how many of you have gone through a formalized 12-lead program before? Okay. How many of you have taken a class from me before? Some say that's okay. So you're either a glutton for punishment or you like what you have. How many of you are acquiring 12 leads or interpreting 12 leads currently on a day-to-day basis? Good number of you? Okay. So for those of you who raised your hand where you're acquiring and interpreting, here's the next question. How many of you feel comfortable with your interpretive skills? Not as many hands. Okay. So this is always an ongoing process, and while I feel I'm very experienced when it comes to 12-lead interpretation, I by no means am an expert. I learn every single day. And I want to throw that out to you as well, because what I'm going to give you today gives you the foundation. It's a starting point. And even if you've been through a 12-lead interpretation class before, there's going to be a lot of good information here. A lot of you will be a review, but there's also hopefully going to be some new information for you that you can build on. And I will tell you, I'm one that passes on all the time. There's a lot of self-study that has to go into this, and I encourage you to stay current. One of the handouts that I provided for you, if you want to pull that out real quick, is a 12-lead reference list. And these are books that I have found very helpful throughout the years to learn more about it. So if you are so inclined, search those out. A lot of great information, and it helps build, again, those foundational skills for interpretation as we go. So the layout of today, the booklets that you have, those are yours to keep. So feel free as we go through, take notes, draw pictures, whatever helps you to learn. So I put this together to kind of mirror what we're going to put up on the screen. Now I will tell you, you will see content up on the screen that's not necessarily in your booklet. So again, certainly that gives you an opportunity to take notes along the way, and I will try to emphasize specific points as I go as well. So it's laid out in 6 different sections. The very first one is labeled Essential Interpretation. That's the foundation of the 12-lead electrocardiogram, where we talk about what a STEMI pattern looks like. And I realize some of you already have that background, but it's always good to go back and review that. So by the time we get done with section 1, most of you should feel comfortable, if not already, with what the STEMI pattern looks like and what we're looking for as we interpret 12 leads that we're faced with. Module 2 jumps into acquisition as well as transmission. One of my pet peeves throughout the years is how we acquire 12 leads. A good percentage of the time, they are not acquired correctly. In other words, the patches are not in the correct place. So I try to stress proper patch placement, so you make sure that you're looking at what you need to look at to help with your interpretive skills. So we'll talk about that. And then certainly EMS agencies, many of us will transmit that EKG to give prior notification to the hospital. And we currently, in Lucas County, I'll talk about my system, we currently have that in place where we can transmit from the scene that allows the hospital to have that information even in advance of that patient arriving at the hospital. And it actually helps speed time to treatment. Modules 3 and 4 kind of go together, where we define more accurately what the acute coronary syndromes are. We talk about patient presentation, and then we couple that all together along with the EKG to help give us better definitive decision-making process for those patients. Module 5 talks about the high acuity patient, probably my most favorite module to teach. There's a lot of things that we can glean from the 12 lead that will assist in your ability to know what the next thing is going to be that's going to happen to your patient so you can prep for that. So there's a lot of good information. You just have to know what to look for and how to interpret that and what to do with it. And then towards the end of the day, when you guys are very tired, your brain is full, I give you probably the most difficult section to teach. And that is the patterns that will mimic infarct, the things that's going to cause problems with your interpretive skills in the field. Now, I will tell you, when this program was first put together 20 plus years ago, it was never intended to have all of the modules taught on the same day. Typically, we teach half, turn you loose, go in and get some experience, and then come back and teach the last 3. That being said, you're going to get all of them today. So that's why I said there's a little bit of an overload here. You're going to get a lot of information. And even if you walk away today thinking that you're still somewhat confused, that's okay. Because I expect of you to go out, do some self-study on your own. If you have a difficulty in a specific area, ask questions. I'll give you my contact information. I can be a resource for you. Certainly, if you're students, go back to your instructors. They can share some of that information with you as well. And I'm also going to give you some websites that you can go to assist you with your study of the 12-lead EKG. Okay? So that's kind of the layout of today. So let's jump into Module 1. So if you will flip to that section in your handout. The goals here are for you to recognize and localize acute myocardial infarction, what we know as a STEMI on the EKG. And if you don't feel comfortable yet, hopefully by the time we're done, you will, knowing what that indicative pattern looks like. So I'm going to jump right in, and these are what I've labeled as pearls. So throughout the day, I'm always going to go back and reference these pearls. These are pieces of information that are greatly important to keep in mind as you acquire 12 leads on all of your patients. And here's number 1. If you don't remember anything else out of today, please remember this. A normal 12 lead does not rule out the fact that someone might be suffering from an acute coronary syndrome or suffering from an acute MI. Jot this down. 40 to 60% of patients, 40 to 60% of patients will not present with EKG changes within the first several hours of an acute ischemic event. 40 to 60% of patients will not show EKG changes in the first several hours of an acute ischemic event. Does that concern you? It should, because many times we try to rely on the 12 lead to give us all this great information that we can work with. The problem is, it's not always going to be there. What is a positive on our side, and I'll talk from the pre-hospital setting, normally we do see a transition of the EKG. Why? Who can tell me why? When a patient starts to experience symptoms, are they jump on the phone right away and call 911? No, they wait, don't they? Sometimes several hours, a day. And many times the EKG has transitioned by the time you get there. But if you have an immediate response, an immediate call for help, you may be doing serial EKGs one after another, and you're basically seeing a normal EKG, but you have a symptomatic patient in front of you. Sometimes you can't put the two together. I just want you to keep that in mind. And the other reason I stress that is your 12-lead device, the 12-lead that comes spitting out of your device, we should not be using that as a triage tool. In other words, normal EKG, you can't be having an MI. That is not true. You got to keep it in perspective, and I'll address more of that later as we go through today. Here's pearl number 2. The 12-lead ECG stands in the center of the decision-making process when it comes to not only the assessment, but also the treatment of the ACS patient. Now, we've always been taught, treat the patient, not the monitor. Well, that's not necessarily true in ACS care. We have to put the pieces together. And one 12-lead does not a trend make. So if you're with a patient for 20, 30 minutes, taking a snapshot or a 12-lead right at the beginning of care isn't enough, because symptoms can wax and wane, EKG changes can wax and wane also. So something may transpire 10, 15 minutes down the road, and if you're not evaluating it, you're going to be missing that from the picture. So serial EKG is a ticket when it comes to the ACS patient. Here's the third pearl. Your patient's story is very important. Let me give you an example. Pre-hospital setting again, you're at the side of a patient, you start inquiring, you start asking the questions, you're very methodic in your approach, asking about chest pain, respiratory difficulty, OPQRST, the whole gamut of an appropriate assessment. You think you have a fairly clear picture of what's going on with the patient. You acquire a 12-lead, you put all the pieces together, you transport your patient off to the hospital. transfer the patient over to the hospital bed. Nurse comes in, starts asking some of the same questions that you had already asked of the patient. And the story comes flowing from your patient, and you do a double take. And you're thinking, that's not what they told me. The story is completely different. I'm sure you've all experienced that. So that's our challenge. But it's very important that you listen to what your patient is telling you. Making sure you're asking the right questions. I was always one where I was very methodic in my approach. I made sure that I asked all the specific questions. I wrote down the answers, and then I evaluated what that meant to the patient presentation as well as what I was seeing on the EKG. And then we put all the pieces together. And that will make your job much easier. Something to remember. Cardiovascular risk factors. There are a number of them. They should be part of every patient evaluation. Especially with the ACS patient, the more risk factors they have, you should have a greater index of suspicion for an ACS type presentation. And later on, I'm going to give you some patient presentations where this plays a vital role. And we'll talk about how we approach that. So let's talk about your 12 lead for just a moment. The device that you use, and it doesn't matter which one. It could be a Stryker Physio product, it could be a Philips product, it could be a Zoll, it could be a Hewlett-Packard. It doesn't matter. That device, very expensive device, many of them are $35,000 to $40,000. All they are is an expensive voltmeter. They look for electrical activity within a certain parameter. And that electrical activity in that parameter is printed out on a page for you to evaluate. That's as simple as it is. Although you have to have good interpretive skills to figure out what it is you're looking at and how to interpret that flow. So internally, your device captures leads simultaneously, and each lead gives you 2.5 seconds of information. So from left to right on your 12 lead, you have 10 seconds full information to evaluate during the time that that's required. This is a standard 3-row, 4-column format. So you've got 3 rows, 1, 2, 3, and then you've got 4 columns. There's 1 column here, second one, third one, and fourth one. So in this first column, leads 1, 2, and 3 are acquired simultaneously. Then it flips over and gets the next column, and so forth. Here's the fourth pearl. Very, very important. When you acquire a 12 lead on a patient, you are putting patches on the left chest, not the right. So everything on your 12 lead, keep in mind, is in reference to the left ventricle. You should be thinking about left ventricular action. And when a person infarcts, they typically infarct their left ventricle. Now, I realize you can have right ventricular infarct, and we'll talk about that later. But I just want you to keep in mind that the standard 12 lead references the left ventricle alone. So as we go through here, if you see a number at the bottom of the screen, that should correlate, if I did this correctly, to the page that you should be on in that module. So on most 12 lead devices, they have built into them an interpretive algorithm. Nice to know information. If that device stamps it as an acute MI suspected, or whatever terminology it uses, doesn't matter what device you have, most of them are 96 to 98% accurate. So what does that mean? You can pretty much go by it. If it stamps it as an MI, that's probably what it is. Although, you need to keep this in mind. Let's say you acquire a 12 lead and you as a medic or nurse pick up an indicative pattern for injury. You can see it. But when you look up here, there's no acute MI stamp. Guess how often that happens? 48% of the time. So again, it goes back to, you're smarter than the device. Remember, it's only a voltmeter. If it can't see specific things, it's not going to stick its neck out and stamp it. So that's why it's nice to look at this. Your interpretive skill becomes very important because you may pick up something that the device cannot measure. So please keep that in mind. A couple other things. Now, it's been a long time since I've been out of paramedic training, 1979, when the students, when you guys go through 12-lead interpretation or just rhythm interpretation, are you guys still using calipers? Do you use calipers to measure anymore? Barb, you probably remember those days, don't you? Yeah. What's nice with the 12-lead is the fact that the measurements up here are very accurate. So if you want to know what a PR interval is, just look up top. If you want to know what the QRS measurement is, look up top. It even goes so far as to give you QT, QTC measurements, and it can also do axis deviation. So basically what I'm telling you here is, if you want to know what certain parameters measurement-wise are, look at the top of your 12-lead, and you can go by those numbers. There is also a place to input patient information, whether it be a patient ID, number, name. That way it can be associated back to that patient. And then towards the bottom, we'll talk more about this in Module 2, there are specific stamps on your 12-lead that tell you exactly which device this came from, as well as some of the other measurements when it comes to frequency response and paper speed. But we'll talk more about that later. So on page 4, what I'm going to cover with you here very quickly is very basic and elementary. I want to talk about the QRS complex for a few minutes. Each component, Q, R, and S, are not present in every QRS complex. I think you all know that. But just to kind of get at the very basic level, an R wave is always a positive inflection. It is never negative. If we look at the Q wave, a Q wave is always negative, and it always precedes an R. And then the last component is the S wave. S wave, again, is always negative, and it always comes after an R wave. And that makes up our QRS component. So let's talk about Q waves for just a moment. We don't put a lot of emphasis on Q waves. We don't spend a lot of time on it in this program. But what's worth noting is a Q wave can be normal or abnormal. And the way we tell the difference is by its width on the EKG. So what's classified as normal or physiologic has a measurement of less than one small box on your EKG paper. And I'm kind of old school. I always measure in milliseconds. At 40 milliseconds or one small box, which is 0.04 seconds, a Q wave that is very skinny or less than one box is considered normal. Q waves that are wider than one small box are classified as pathologic or abnormal. Typically, when heart tissue dies, it becomes electrically silent. Electrical waves will bounce off of it and produce a negative complex. And the way we know they're from pathology is by their width. So we will evaluate some of those today in the 12 leads that we're looking at. So here's our first problem. What happens if I'm looking at the QRS complex and I see this? Is this a Q? Is this an S? What do I call it? There's no positive component at all. Basically, we put the two letters together and we call it a QS complex. And if it meets the width parameters wide, it's considered pathologic. And we're going to look at some of those today as well. So this is the area that gets a lot of analyzation. We're going to be talking about this all day long. It's the J or the junction point. It's the tail end of the QRS complex. What happens during myocardial ischemia is the J point deviates off the isoelectric line. It can either be pushed down, negative, or it can be positive, above the line. So when we have a current ischemic event going on, we're going to evaluate this area of the EKG and note its position, and it gives us great information about what may be going on. So the J point becomes vitally important in 12-lead interpretation. Beyond the J point is the ST segment. Most of you know that is the beginning of repolarization. But I want you also to remember that the J and the ST are married or linked together. So when the J point is pushed up, it will drag the ST segment with it. So if this is up, the ST is going to pull with it. If the J point is depressed, the ST segment will drag down with it. So it's not enough just to look at the position of the J point, but we look at what the ST segment is doing as well. And we're going to put those pieces together. So I don't believe this is in your hand. Well, I think it is. I'm sorry. Here's a cutaway of lead 2. I've blown it up for you. And I want you to note the position of the J point in the short rhythm along with the ST segment. And the thing I want to note here is the fact that the ST segment is not normally flat. It has a concave contour to it. So if you wanted to do a little artwork, draw a circle around it and give it eyes, it should produce a smiley face. If you're seeing a frown or it's flat, that is abnormal. So that's something we're going to evaluate today as well. Now let's talk about symmetry. Many times we use symmetry in stroke care, looking at facial presentation, looking for facial droop. Well, symmetry plays a role in EKG interpretation as well, and it's specific to the T wave. T waves are normally or naturally asymmetrical. So if I were to draw a line through its peak and draw vectors, you'll notice that these are not mirror images. They are offset. That's the way a T wave should look. When a T wave becomes very symmetrical, tall, peaked, and begins to bow out, and you're all familiar with the term tombstone T waves, that is an abnormal presentation or finding. So we're going to pay attention to that as well. So on page 7, this is just a little drill to kind of train your eye. You will find a series of complexes. They are blown up. I realize they distort when we blow them up, and you may not be able to appreciate the very small boxes of the EKG, but what I would like you to do very quickly here is take your pen, pencil. I want you to mark the position of the J point. And then we're going to go through these in just a second. And I'm going to have you tell me, is that J point at the isoelectric line, below the line, or above the line? And again, this helps us prepare for these deviations that you need to look for. So as we look at this first complex, if we first look at the QRS complex, you see that we have an R wave, we have an S wave. Is the J point at the line, below the line, or above the line? Anyway, below, okay? And if you look at it, it might be a box or more, and it's not a nice perpendicular edge. It's more curved, but it looks like it's slightly depressed. Good. How about the second complex? Good. What's this right here? Q wave. Is it normal or abnormal? Normal, because it's skinny, right? Here's our R. Do we have an S wave? Here's the S right here. It's been drug up. Our J point is here. So you're elevated probably 3, 4 boxes. Good. How about this complex? Does this complex look weird to you? What's wrong with it? It's predominantly negative. Is that normal? Well, it's relative to the snapshot that we're taking. We don't know what lead this is. This might be normal. We'll talk more about that later. But here's an R wave, here's an S wave. It looks like it's right at the line. Good. How about this one? Say again? A little bit below. If anything, it's probably less than a box. And then how about this complex? Above. Good. Predominantly negative QRS complex, but the J point is actually elevated above the line. Good. So if you're having difficulty realizing the deviation up or down, what you can use as a comparison point is what's classified as the TP segment. In other words, that section of the isoelectric line in between complexes. Why do we use that area? Because the heart should be electrically silent. It should be at the isoelectric line. And then we kind of draw a comparison across and note whether this is elevated or depressed using that as a reference. So on page 8, a couple more complexes for you to look at. As you look at complex number 1, again, J point elevated, depressed, or at the line. Good, it looks like it's slightly elevated. If you look at the contour of the ST segment, nice concave shape as it should. T wave looks a little peaked. How about the second complex? Good, elevated. How about the third? Elevated, good. How about the fourth? What's odd about this one is the fact that the QRS complex is wider. And the J point is actually right here. So that is depressed, and you have a depressed SC segment, and it's pulling the T wave down with it. How about this one? Elevated, not a real good perpendicular edge here. It looks more curved, but it looks like it's elevated by one box. And then how about this one? Good. Pretty simple, right? So what do we need to know to pick up the pattern or the process of infarct? Here are the two things. We need to know what we're looking for and where we're looking at. And we put those two together. And what we're looking for is JST segment elevation of one small box or more, and it has to be present in 2 or more anatomically contiguous leads. What does that mean? Who can tell me?
One lead followed by next.
Okay. So we've got patches all over our patient's body. Some of them are looking at similar areas of tissue. So if I see changes in one and I have another patch that's looking at the same area, wouldn't I expect to see changes in that one as well? Yes. And we need to have 2 or more. So it's not just one standalone lead. We should see it in more than one lead, actually more than 2 leads, to kind of confirm that that's truly what we have going on. So that's our rule for picking out the infarct process. When we have that, it's presumptive evidence of acute myocardial infarction, or what we've labeled a STEMI. And that is also the indication for acute reperfusion therapy. And that can take the form of either clot-busting drugs, thrombolytics, or triaging your patient to a cath center to have angioplasty, balloon, or stenting performed. And when we get to modules 3 and 4, we're going to talk about that definitive therapy and what that means for your patients. So take a look at the EKG on page 10. And what I've tried to do here is anytime you have an EKG that we're going to get to, because it may be hard to see up on the screen, you're going to have the same thing in front of you that you can make notes or annotate. So if we look at this EKG on page 10, what we want to do early on here is we want to look for the indicative pattern of infarct. We're looking for J point and ST segment elevation of one small box or more, and we're going to look for it in multiple leads. And I know some of you already know what this is, but what leads give me that pattern?
2, 3.
Good, 2, 3, and AVF. We see that indicative pattern. So if we know what 2, 3, and AVF represent, we would know exactly where that is. And you all pretty much know this. What is it? Good, inferior wall. Because 2, 3, and AVF are views of the inferior wall of the left ventricle. Good. So let's talk about lead views for just a moment. I can't stress enough how important the position of the positive electrode is. The positive electrode is the camera or the eye. So when you put patches on your patient's chest and limbs, if you know where the positive electrode sits, you know from which direction the picture is being taken. And while you may think that that's not important, it is. Electrical flow is important. It will make you better at interpretation if you understand how these pictures are being taken. So we're going to talk about not only your limb leads, but also your precordial leads in this next section here. So on your 12 lead, your lead views are grouped. On the left-hand side of your EKG are your limb leads, 1, 2, and 3, as well as your augmented voltage leads. And then on the right-hand side of the EKG are your representations of your precordial or chest leads. They are color-coded for you because we're going to talk about what their lead views are. So when you have your patient all hooked up, essentially that's what they look like, and we're going to talk about patch placement in just a few minutes here. But here's something you probably didn't think that you were going to have to talk about today. We're going to talk about electrophysiology. We're going to do it very briefly because it lends importance to what you guys do when it comes to acquisition. So tell me if this sounds correct to you. We all know that the SA node is the inherent pacemaker of the heart. It reaches its threshold or potential to fire much faster than any of the other cardiac cells. The SA node has an inherent firing rate, as you know, of 60 to 100. As the impulse comes out, there's a wave of electrical flow. The top chambers of the heart depolarize, contract, and that's how a P wave is represented on your EKG. Everyone knows that, correct? Pretty simple. As that impulse gets down to the AV node, that's the next inherent pacer for the heart. AV junctional area has an inherent firing rate of 40 to 60, and the AV junction is made up of not only the AV node, but also the His bundle. That impulse, once it hits the AV junctional area, is held for about 1/10 of a second, which allows for blood to transition from the top chambers to the bottom chambers. So that delay is represented on your EKG as a measurement from the beginning of your P wave to the end of, or where the beginning of your QRS complex is. And that's how we get our PR segment. And most of you have memorized what that measurement should be. As the impulse is passed on, it goes down into the Purkinje system. Ventricles depolarize, contract, and that's how we end up with our QRS complex. Everybody understands that, correct? Do you understand this? I know when I went through training back in the late 70s, they talked to us about the mean cardiac vector. So I have to ask the question, do you guys know what that is, or has it been taught in your current education? So the mean cardiac vector is this. As electricity is flowing through the heart, it's going in all different directions. But if we took a sum of all the electrical flow and gave it a directional force, it would be down and to the left. Right here. You know that when we hook our patient up with patches, we're looking at views of the heart that are offset by 30 degrees all the way around. So the reason I stress this is, if we're taking a picture of the heart, it's in reference to the way electricity flows. So if electricity is flowing down and to the left, and I'm taking a picture from different spots, what I see in my EKG is related to that flow. And if that flow changes, or my patches change, the picture will look different. Most people that do not understand this don't have a fine capture of how to acquire a 12 lead and how to interpret it. I'm telling you that this is a foundation of what you need to know. Okay? So let's take this a bit further. As electricity is emitted out of a cardiac cell, as electricity flows directly towards a positive electrode, that shows up as a positive inflection on your EKG. So right up here, electricity is flowing directly towards the camera. What I'm going to see on an EKG is a positive complex. It will be above the isoelectric line. If electricity is flowing away from a positive patch, I should see a negative complex. Now here's the challenge. What if I have electricity that's flowing perpendicular to my camera? What you might see in that realm is a biphasic complex, some on top, some on bottom, or it may minimize your amplitude and take the complex away completely. For all those who have been through ACLS training, they talk about the rhythm asystole. What do they tell you to do? Monitor it in multiple leads. Why? Why do they tell you to do that? Because of this. You want to make sure you're picking out a lead that doesn't cause minimization of amplitude. And you can actually see a patient rhythm go flatline if you choose a lead that's monitoring perpendicular to the flow. So we try and surround that activity, making sure that there's not something there. So let's talk about leads 1, 2, and 3 first. Probably the ones you're most familiar with. Leads 1, 2, and 3 are bipolar leads. In other words, we're measuring electrical flow between a positive and a negative pole. Positive is the camera, negative is where the camera is pointed to as the reference point. Okay? So let's talk about lead 1 first. Lead 1, all I care about is where the positive electrode is, and it happens to sit on the left shoulder. So my reference, my picture being taken is in reference to the negative, so it's taken in this direction. And we know that the mean cardiac vector is down and to the left, so I'm monitoring electricity in a perpendicular fashion. Electricity is flowing this way. I'm taking a picture here. So I know when that happens, I'm going to have minimal amplitude in my complexes. So it's not uncommon in lead 1 to see very small QRS complexes, and that's normal. It's normal because I know how those are captured. But more importantly than that, this cup is the heart. Sits to the left of the chest, blood out, shifted to the left. So if my positive electrode is on the left shoulder, and I'm taking a picture this way, and everything is in reference to my left ventricle, lead 1 looks at the lateral wall of the left ventricle. So lead 1 is a lateral view. Now let's move on to lead 2. Lead 2, positive electrode, is on the left foot or left lower torso. That's my camera, shooting a picture up to the bottom of the left ventricle. Another word for bottom, of course, is inferior. Now as we look at electrical flow, we know this electricity is flowing directly towards a positive patch. We should have nice upright complexes in lead 2. That's why we choose it most often for rhythm interpretation, because it gives us nice upright complexes. So here's a representation of what lead 2 looks like. Everything's positive. We have nice positive complexes to look at. Now let's talk about lead 3. Lead 3 also has the positive electrode on the left torso or left leg. Well, that's very similar to lead 2, is it not? What's the difference between lead 2 and lead 3? Anybody tell me?
The negative electrode switches sides.
Correct. So in a lead 2, the negative electrode is here. In a lead 3, the negative, so all we're doing is shifting the camera 30 degrees. So we're getting a slightly different picture of the bottom of the left ventricle. But again, because most of the electricity is flowing directly towards the patch, again, in lead 3, I should see nice, upright complexes. Any questions on leads 1, 2, or 3, or how they're captured? Lead 1 looks at the lateral wall. Lead 2 and 3 look at the inferior wall of the left ventricle. Now let's talk about your augmented voltage leads. AVR, AVL, and AVF. There was a gentleman, physician by the name of Frank Wilson back in the late 1800s that started playing around with Einthoven's triangle and came up with 3 additional views of the heart by manipulating the polarity of the patches. So what an augmented voltage lead is this. It's one positive electrode and all of the other electrodes become grounds, which makes the heart the electrical negative. So wherever the positive patch is, it's monitoring directly back to the center of the heart. And by doing that, we get 3 additional views. So let's talk about AVR first. AV, augmented voltage. R tells us where the positive electrode is, and R here is in the right shoulder. So if you think about it, our picture is being taken in this direction. The mean cardiac vector, electricity is moving away from that positive patch. So what we should see in AVR is completely negative complexes. If AVR is upright, what's wrong? Your wires are in the wrong place. You have your patient hooked up incorrectly. AVR should be negative. So here's the question. Since we're taking a picture from up here, the top side, what information does it really give us about the left ventricle? Well, the early teaching was it didn't tell you anything. So for many, many years, we did not use AVR for infarct recognition. We noted its presence, we noted that it was upside down, but it didn't really tell us much more. That thinking has now changed. And later on, I'm going to give you some information about the importance of AVR and how it can help you with infarct recognition. But I'm going to hold on to that. We're going to talk about that a bit later. So just by the fact that your AVR is inverted, it gave validation to your EKG that the wires were in the correct place. AVL, augmented voltage. L stands for specifically left shoulder. So positive electrodes on the left shoulder, heart's electrically negative. We're taking a picture in this way. In reference to the mean cardiac vector, again perpendicular, and it gives us another view of the lateral wall of the left ventricle. Amplitude will also be affected in this lead because of that perpendicular monitoring. So what lead does this mirror that we've already talked about? Lead 1, good. AVF. Big F on the end stands for foot, specifically left foot. Heart is electrically negative. Gives us a slightly different, offset again by 30 degrees, another view of what area of the heart? The bottom. The left ventricle, bottom of the left ventricle, or another inferior lead. And because electricity is moving directly towards the patch, we have nice, again, upright complexes. The reason they use augmented voltage is when the polarity changes in the patches, one positive, the rest grounds, it would make the amplitude so small you couldn't recognize the complexes. So internally in your 12-lead devices, the amplitude is bumped up automatically by your device when it acquires those leads, so you can see them. So that's where the terminology came from. Nothing you guys have to do setting-wise. Internally, your device does it all by itself. Any questions about the augmented voltage leads? Yes?
AVL, that was a negative deflection or positive.
AVL can be biphasic, or you can have minimal amplitude because you're, again, perpendicular fashion of monitoring. Now let's talk about your chest leads. True unipolar leads. Each patch that you put on your patient's chest is a positive electrode, a camera, taking a picture directly back to the heart and looking at that specific area anatomically. So V1 and V2, how many of you have your chest lead placements committed to memory? As far as you don't have to look it up, you kind of know exactly where they go anatomically, but over time, it's very easy to remember. But V1 and V2 sit along the sternal borders in the fourth intercostal space. In reference again to the way the heart sits in the chest, they look directly back into the septal area of the heart. So V1 and V2 give us representation of the septal region, septal leads. V3 and V4, positioned on the anterior left chest, sitting right over the anterior wall of the left ventricle. So V3 and V4 are your anterior leads. We then get to V5 and V6. Lateral chest placement, slightly different vantage point for the lateral wall of the left ventricle, because that's where the camera sits. So what I'd like you to do on EKG on page 14 is center your eyesight from V1 to V6. And you notice a normal transition that takes place. When we start off in V1, the QRS is predominantly negative. By the time we get to V6, it's predominantly positive. Why is that? Think about it. The camera is moving, correct? From V1 to V6. As I get to V6, it's more in line with the mean cardiac vector. So as I start out, it's predominantly negative initially. By the time I get to V6, it's predominantly positive. They call that R-wave progression. That's the way it should flow. The reason I point that out, what if there was an infarct going on in this region of the heart that my precordial leads would pick up? Guess what? The R-wave progression will not flow correctly. You will see complexes remain predominantly negative all the way through V5. So it's additional information that helps us with our interpretation. And I'll point those out when we get to those. So just to summarize again, our lead views. 2, 3, and AVF, colored green here, share in common the positive electrode on the left lower leg. They are your views of the inferior wall of the left ventricle. You have 4 views of the lateral wall. 1, AVL, V5, and V6. What's interesting to note between these 4 leads, Look at the camera position in 1 and AVL and the camera position in V5 and V6. While they're all looking at lateral tissue, this is a high camera angle, this is a low camera angle. So leads 1 and AVL are considered high lateral views. Leads V5 and V6 are considered low lateral views because of their position. V3 and V4, look at anterior tissue, and then V1 and V2 are your septal leads. So now we know what we're looking for. J, ST segment elevation, 1 box or more, present 2 or more anatomically contiguous leads. We kind of have a concept now of what our lead views are and what areas of tissue we're looking at. So if you guys take a look at the EKG on page 16, see if you can put all of that together and render your diagnosis to that EKG. We're looking for the indicative pattern of infarct, which is J point ST segment elevation, 1 box or more. We're looking for an anatomic grouping. And what anatomic grouping shows up for you? Good. 2, 3, and AVF. Everybody look at that. Leads 2, 3, AVF. We have J point ST segment elevation. We've got big, tall, pointed T waves. We know that they share in common views of what area of the heart? Inferior wall of the left ventricle. So this is an inferior wall STEMI. Pretty simple stuff, right? Although it does become more complicated as we go. But general interpretation-wise, it's as simple as that. How about the one on page 17? Again, look for the interpretive or indicative pattern. Look for your anatomic grouping. And there should be 4 leads that stand out to you. Look at V1, V2, V3, V4, V5, maybe a little suspect, but definitely have got it in V1 through V4. So we know that V1 and V2 are our septal views, V3 and V4 are anterior views. So if we put the 2 together, anteroseptal infarct. Questions on that at all? So let's add some more information to this. During early onset of myocardial ischemia, if we were lucky enough to have our patient attached to a monitoring device at the exact time they had an insult to their heart, the very first thing that will change, even prior to symptoms, is T-wave shape and contour. T-waves become very tall, they will peak, and they become very symmetrical. So that is an early sign of ischemic change. And that may take place in the first several hours. Obviously, as that process continues, during the acute phase, then we start to see J point and ST segment deviate off the line in combination with that hyperacute T. And you may also witness this. That T wave will dynamically flip over. So you have all those things going on. Hyperacute T, tombstone looking, J point ST segment elevation, and then the T wave flips over. And then if that infarct process goes on for a long period of time and skin or cardiac cells begin to die, you may start to see the development of a pathologic Q-wave. So it's a very dynamic process. Now, I'm sure some of you have already seen 12 leads, where you're looking at the top interpretive algorithm, and it may say something like this: septal infarct, age undetermined. Do you know what that means? What we're looking at there?
Q-waves.
Q-waves. So it's very possible your patient has an old infarcted area of the heart. They have developed a pathologic Q, and that's what your device is picking up. While it's not a current event that's ongoing, it's giving you information in the algorithm that there's past event there that is picked up by your device. So you should understand what that means. But if you're looking at a complex like this,